something like that. So to have him now be a master's in nursing nursing student is like very sweet because they remember him.
That's great.
I
That's
know.
great.
Very sweet. Anyway, thank you for coming to what did we say last week? We're like informal in conversation, but formal in process. This is a good example of that. Welcome to our first new domain meeting in October. Again, we have our unique cycle this fall where we have a meeting every week. This is the meeting focusing on new domains, so language barriers and incarceration status. Next week is the enhancements meeting that focuses on coding for food, program classification, etc. Thanks. Okay, next slide. Welcome, everybody. I'm Sarah DeSilvi, the Director of Terminology for Gravity, and your very happy facilitator. I'm so grateful to see all your voices. Welcome. And then we do mute ourselves upon entry. As I mentioned, we're informal in process. We really do appreciate your voices. We address a lot of really either technically or ethically complex issues in our time here. We really want to make sure that everybody leaves here feeling that they understand what is being discussed. There's a saw outside. Can you guys hear that? Is the saw complicating your hearing?
No.
Great. It is a very loud saw, so that's fantastic. So please feel free to add chats, add anything to the chat, and please put it to everybody because I'm just so accustomed to reading things out loud. So if you have a question, I'll read it out loud and we'll get it into the meeting. And here we go. Next slide. We have a lot of new content. This is our classic antitrust practices slide. Again, we are, as a standards initiative, we have to follow antitrust practices regulations and guidance, and so we have to comply fully with federal and state antitrust laws. I have moved beyond reading this whole thing, but I just want to note that we recognize that it's not just direct adherence, but also adherence to any inference of it. So please just avoid any behaviors that might be construed as an antitrust violation. Next slide. So we have some welcome and announcements, and then next slide is really exciting. We are able to announce our 2025 domains, which are pretty critical and very, they're going to be equally complex, or perhaps even more complex than the issues that we're addressing now, but they are a long time coming. We'll then go through language elements and then incarceration status elements, and then no new updates in all domain revisions. And then we're going to close with community homework and next steps. Next slide. Next slide. There is nothing new here. We just wanted to continue to notify you that if you wanted to comment on the utility and security IC10CM, you can do that through November 15th. The technical work stream is continuing to meet Wednesdays 1 to 2. We're having really great conversations regarding referral workflows so that it can be inclusive of the complexity and diversity of the ways that we take care of people with clinical and social care practice. The next meeting for the implementation work stream is October 31st. The topic is to be determined. And then that will possibly be the last affinity meeting of the cycle, but more to come. We try to give each other a break in the holiday season. Next slide. Any questions on the brief announcement? Okay, next slide. This is us. We're the Gravity Project. We are a collaborative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. We cannot do what we do without our amazing members. We're incredibly grateful for them. We do want to note, and I say this every time, that it's unusual but necessary in our work that we are not just that don't just follow a classic HL7 model with, sponsor members, where we have these designated members really from a social justice framework. So voices that are really critical from our work that are not sponsoring the work, but we pull them in because we cannot do the work without them. Again, it's just good old-fashioned social justice community organizing practices applied to the mission at hand. Next slide. This is our 2024 roadmap. Super excited to say that the Coding for Food work kicked off. So this is our really, so it was dotted line for some time, but in the alternating meeting is where we're developing the reimbursable terminology to support critical food as medicine initiatives. For anyone who knows me, you know that originally at Gravity, I was simply a food insecurity subject matter expert and a former farmer. So coming back to Coding for Food and Food as Medicine is very, very close to my heart. And then this in the, we're still doing new use case work, and we'll talk more about that going forward. We're working on the ID, aligning our ID with US Core 6.1. And again, as always, improving our education. I mentioned this last time, but we also are trying to create artifacts of knowledge that are not just education. Like we really are on the leading edge of solving all kinds of sticky wickets and problems. And so we're working with our membership to make sure that we can represent that knowledge in a way that can be pointed to. Next slide. This is a new slide, but it's not new. We have presented this repeatedly. For those of you that remember last summer and fall, we worked on an initiative to really deeply center the voice of social care providers and experts, because our membership model is like the Senate. It has equal representation across each of the different entities, stakeholders. But the burden of care is largely on our social care friends. And so we had a little moment of deep diving with social care experts to try to make sure that we could pull their perspectives into our use cases, our models, our direction. There's that final report that's available on the Confluence. The final report has had legs. But one of the things we realized is we have not been representing very well how we are accountable to each of those different use cases. So going forward, at least in this meeting, I'm trialing a method where when something we're talking about aligns with something that was kickstarted and elevated and supported in the social care voice co-design work, I'm going to pull that little use case circle into the slide so you can see, like, it might not be the full answer to what happened in the social care voice co-design work, but it is our attempt to be accountable within our scope, which is developing data standards. So again, really trying to demonstrate how we're accountable to that work, and we are due to create a 1-year report. And so that should be coming shortly. I see, let me see. Oh, so Christy, I'm wondering if we can help the amazing Christy Clark.
Yes, we are speaking.
Thank you so much. Yeah, thank you. Our friend Christy. So applying this, you'll see on the next page. So our 2025, so next slide. No problem, Christy. You matter. We care about you. We care about everybody. So looking ahead to 2025, our new domains are as follows. So for spring 2025, we are, this has been in the works for like 2.5 years. We're leaning into topics and person level discrimination and chronic stress. So this is built off and really catalyzed by a submission of our dear friend and member of the American Medical Association, catalyzed by all of the support that we offer federal and national entities and health equity initiatives. So we're going to be working on documentation and terminology to support person-level experiences of discrimination. This is across all different types of discrimination. The American Medical Association leaned deeply into into racism in their IC10-CM submission this spring, but we are going to be unpacking it and looking at discrimination more broadly, and then very much aligned with our work that we are doing right now with incarceration. We have always intended to pair person-level discrimination with measures of chronic stress, minority strain, weathering, and adverse child experiences. I am going to be, of course, necessarily surrounding myself with people and surrounding the Gravity team with people to help lead this well. I hope to be more of a helper than a leader in this work, just from an appropriateness perspective, but just know that those are the spring domains. And again, for anyone who's been around, I think they were first proposed and on the roadmap 2 years ago. So it's good to make sure it's good to lean into them now, especially supporting our friend at AMA in their submission this spring. In the fall of 2025, we are going to be working on extensions of our food insecurity work with neighborhood food access and extensions of our housing insecurity work with neighborhood safety. Again, we've always planned to go from the person in the household to the community with these domains, and knowing that this is the social and social determinants of health. So that will be our work in fall 2025. We also are going to be continuing our work on enhancements to existing domains and continuing our work with coding for food, housing instability and homelessness enhancements, and more. You'll see very shortly that we are really honored to partner with our friends at CDC on a gap analysis of our housing concepts and trying to make sure we have sufficient screening methods and intervention methods to represent all the ways we help individuals with housing instability and homelessness. You can see that the coding for food work, as HCPC work, supports the reimbursement use case from the social care voice co-design work. That was the primary way we knew that we could help from a terminology perspective. So within this work group, our terminology work group, we are leaning in to support reimbursement terminology to support social care voice co-design. And then cross-domain enhancements, we're also planning to leverage that weekly meeting, the other meeting, desperately. I mean, as a pediatric specialist and family practice clinician, I have been planning and hoping to address protective factors for a very, very long time, because as we know, social determinants of health are not just negative, right? We're not the sum total of our risk. And so we have really going to be challenging the problem-based documentation and healthcare records with space and intention to document assets and protective factors and gifts. And also knowing that that is, of course, where we intervene a lot in our family-based care, right? Enhancing like protective factors and assets. So that is a likely cross-domain enhancement, and also trying to work on aggregate reporting. That is also a social care voice co-design element. This goes back to our third use case at Gravity, which is analysis of individual level data at population levels to drive policy and structural change, right? We are not naive. It's all very well and good to help an individual. You do not stop the stream until you would change policy, implement structural changes, and address the drivers, right? So that's our hope as well, to make sure that our models can represent aggregate reporting. So if that doesn't look, that is a very, very noble, like 2025, it's going to be both significant and I promise to try to gather the right experts to help us do this well. But any questions on the 2025 roadmap? I'm sure there's many. Or maybe all of you who've been around know that this has been in the hopper for some time, but just know Gravity will go into planning phase on these for the rest of the year, and be, if you are a CDC friend or a CMS OMH friend, I have an email drafted for you very shortly. And Matt Bishop, Coding for Food, meets on the alternate meeting. So this is the new domain meeting. This Thursday next week, and alternating from the meeting next week is the Coding for Food meeting. So in that meeting, we address the Coding for Food. It's basically, we're calling it the enhancements meeting. So it's not just new domain terminology, it's enhancements work, which includes the open program classification, Coding for Food, and then other, like some of the gap analysis work from the CDC will fit in there as well. Any other questions? Okay, next slide. Here we are again. So we we have some significant new content, mostly in incarceration status, and some questions for everyone on the call, and then our SMEs. We have a series of meetings for the rest of the week. So you'll see a lot of new programs and terms in incarceration and language barriers today. And then we go into a series of end-to-end review over the course of the next weeks. We have not had a lot of our definitions drafted yet. So the 2 meetings from now, you'll see some definitions start to populate in line with the intense push to try to update our content. You'll see later in the meeting, we're changing the date at which we release our master because our subject matter expert meetings happen on Friday. So integrating findings from the subject matter experts into the masters is complicated if we release on Friday. So I hope you all are forgiving and we're going to change the date to release at the end of day on Tuesday. That will allow us to ensure the wisdom of our SMEs are integrated into neat findings from the SME meetings. But so we have one more meeting today on identifying concepts, and then hopefully a lot of definitions will come, not next week, but in a couple weeks after that. And then we have a few meetings on end-to-end review before we head into consensus vote. And then again, this is a flexible thing, so if we need to adjust it, we can. The primary deadline we try to aim for is avoiding the holidays and getting our submissions in time for any IC10CM requirements for the March meeting, because the submission deadline is now in early December. It used to be January. Okay, next slide. This is the data principle slide. I just left this slide and then the data justice slide because certainly the incarceration status and language access domains that we're addressing have us leaning in to that 6th principle more deeply than we have before. And a lot of our decisions about whether or not it's right to add any data come from like a really attentive desire from our subject matter experts to guide us in what data is safe and what data is helpful as we work to tell critical stories. So I'm keeping this slide here because it's very apropos. Next slide. I think it was Milan who said it so nicely this week. We have really lovely subject matter experts who are helping us get this right. I just can't be more grateful. And then this is just the data justice slide, right? Because there's I brought this forward last meeting because as we work to develop terminology from a data visibility justice perspective, preventing discrimination and bias is always on our mind. Right, and really trying to make sure that that we're carefully considering both as we go forward. Next slide. All right, next slide. This is a new slide because of a few reasons. So first of all, Christy, I'm glad you're on the call. So we do, and Matt, this aligns with what you were mentioning before. So we have these 2 terminology initiatives running concurrently. New domain work here, right? And prior and cross-domain enhancements happening next week in that meeting alternate. So we are really grateful for partnering with the CDC, as I mentioned, on this gap analysis and concept development to support enhancements to both housing instability and homelessness. We've long known that we did not have a homelessness screening instrument sensitive to the policies of McKinney-Vento and federal definitions of homelessness. There was just a significant gap in that. And we also are realizing we do not have really all of the programs that are necessary for helping individuals who are either housing instability or unhoused. So we've been doing a background gap analysis in Gravity already, and we're already doing this work with terminology enhancements. So sometimes the things we're identifying in the other meeting are appropriate here because it's all combined, right? So although new domain terminology is development is the focus of this meeting and enhancements is the focus of the other meeting cycle, when something is coming from that enhancements meeting that's relevant for this purpose, the way we identify a gravity gap in the other meeting is this bold purple highlighted concept. Those are all concepts that will eventually need evidence-based definitions and will be submitted to SNOMED CT in the program area mostly, and sometimes actually in the diagnostic area. But specifically in programs, there's a significant amount of gaps, and they're all highlighted in purple on our slide deck. And they're all going to be part of our gap analysis and enhancements work as we go forward in the other meeting. I hope that wasn't too confusing. We're just trying to highlight the integration. So in this meeting, when something's bold and purple, it came from the other meeting. It means it's a gap. We're working on it. It aligns with enhancements, right? And mostly these are in the housing area, and sometimes not. But we wanted to show a through line for anyone who's attending the other call. Sound good? That sounds like okay. All right. Let me see if I'm missing anything in the chat. Okay, great. Perfect. Okay, next slide. As always, so all of our master lists are available on the Confluence. It's going to be now Tuesday, 5 p.m. Pacific time, because we just need to give our team, first of all, working on 2 domains, and that's a lot in general. And we're also working on program classification, and there's another master there. And our SMEs meet at the end of the week. So to get all of that expertise into our master and to give time to integrate things from this meeting, we're giving ourselves until Tuesday. The coding for food masters in food and security, new domains are always in the bottom of domains and the program classifications under cross domain work. You can find all those masters there when they're published. Next slide. Here we go. Okay, next slide. So now, because we're like finalizing and trying to get our concepts onto paper, getting those definitions so that we can work towards submitting them at the end of our consensus vote to SNOMED CT, and getting the definitions right, because then we know what we're talking about. You're going to be seeing everything in bold on the slides going forward, and every concept in bold is going to be something you'll see on the master on Tuesday. And again, I'm a visual person, so I need to see things. So I try to build those kinds of tips and tricks into the presentation for other people if you're need to see it person too. And so these are amazing subject matter experts guiding us in the work of language barriers and access. So we have a few updates, and we all across programs, and we have some thinking that we're working through on what qualifies as a problem. Next slide, you'll see this as we go forward. I'm going to keep on stating, although it's out of scope, we recognize the need for accountability measures whenever we implement this terminology. And luckily, many of us work in places where we can take the knowledge of the need for those accountability measures to the center, and including things like CMS and CDC. Or NCQA, right? So we have our friends in the ecosystem who are listening, and just we feel accountable to saying this out loud, that simply identifying that a person needs to be assessed for preferred language and needs to be offered interpretation, and it's not enough. Like, you need to make sure it works for them. I do want to note also our friends at Siren are working on patient-reported outcome measures for social determinants of health. So those are going to be released eventually, but there's a lot of work in the ecosystem to lean into the accountability bit, and we're just naming that this is required. Next slide. These are our concepts, right? And you're going to see how we're applying them as we go forward. And again, I really want to think through some of the organizational elements, because it's true that right now we're built in person level terms, but when we think about next fall and the work about food access and neighborhood safety, developing concepts that name communities and health system needs, not just person level needs, is something we can start to wrap our brain around. So looking forward to talking about that with our subject matter experts as we go forward. Next slide. So everything in bold here is something you're going to see on the master, right? And the master is a place for us to interact like formally on what we're creating. It's also a place to see it all, like not just on a slide, not just hear me say it. It's very clear how to name things. Like we've level set on ways of defining English language proficiency. Right now, there's just the limited English language proficiency concept in SNOMED CT. We agree it's inferred that it's spoken, but by inferring that it's spoken, it's a little challenging because we also recognize that there's spoken, written, and reading English language proficiency. And we are trying to figure out how to define the preferred language concept as like a problemless statement, and if it's appropriate. And we need to talk through primary language. We just started that last week. And again, I had to shift the meeting to attend my son's ceremony, so this means we're very generous. So on the master this week, you'll see these concepts. This means you're going to talk about them more tomorrow. If you have any reflections on them, let us know. But these are the things that we're leaning into at this moment, and more to come on those. Next slide. Assessment instruments, next slide. I have one new slide here. So again, everything in bold is, and again, SMEs, feel free to interrupt. Take it away if you want to. We have this one concept in bold that you see here. What language do you feel most comfortable speaking with your doctor or nurse? That's in the SAMHSA set. But we note that we prefer communication rather than speaking. And we prefer more broad concepts beyond just doctor and nurse because healthcare teams are diverse. And we don't just have doctors and nurses on our teams. We have community health workers, we have social workers, we have all types of different roles and professions. And so this statement is a little limiting, but it exists. And so it's here. Next slide. What I wanted to highlight, because we have not talked about it yet, I mentioned it at the last call, is there are efforts out there in the ecosystem to develop instruments. And the amazing thing about this group is there also is a great capacity of our subject matter experts to develop instruments. And so I'm prodding them to try to see if we can work on that together. But there was this work of the Demographic Data Element Modernization Initiative, which is a partnership between HL7, Civitas, and American Health Insurance Plans. The focus was exploring best practices in demographic data element standards for health plans. And the important thing to note is none of the questions and none of the approaches they had in the demo project are implemented. So they're not tested and not implemented, and they're undergoing testing right now. So that makes them not able to be included in our work because we don't include things that haven't been tested and implemented. But we do want to highlight that they're working on it, right? So what they have as a draft concept is what language do you feel most comfortable speaking about your healthcare? And that answers the doctor and nurse concept, but doesn't quite answer the communication concept. And luckily we're very close to our friends at Civitas and HL7 and AHIP. And so one of the things I want to do is loop back with them on what we've learned here, because before it goes into testing, if our consensus work has identified opportunities, it might be nice to integrate them into that, into the findings from the webinar series. And they also actually have a reading and writing preference, which was I thought interesting. We haven't talked about that, so we'll talk more about that with our SMEs. But I just wanted to know that there is another initiative out there that's working on filling that gap, and it's going into a phase of psychometric testing over the course of the next couple of years. And I already have it on my action list to inform them about our consensus findings so far. But I want to check in with our SMEs first. And we have the hyperlink to the initiative in the chat. Next slide. Again, always trying to fold things in for all of you. So then this is our example interpreter needed concept. I want to note that there is a lot of approaches in the ecosystem that did not make the cut because they didn't specify the things that we felt like were important. Like there's a preferred language statement on the health leads questionnaire, but it has no context, so it's problematic. And then there's a question on some of the CMS instruments, which doesn't specify context either. So both across interpreter needed, English language proficiency, and preferred language, what you see here is what made the cut from the SMEs. And again, always trying to, I do appreciate the communication focus on this, and our SMEs talked about that as well. Next slide. And then again, we haven't no changes to the CMS question, so English language proficiency. Next slide. We have the spoken English language proficiency gold standard approach in the US Census. And again, thank you to our friend and subject matter expert, Lisa, who is advocating to ensure representation on the answer list there. We appreciate you, but basically this is so well tested, and this goes back to the demo initiative. This is so well tested and implemented. It's absurd to not use it, right? The methodology from the US Census is so like the base. And so our SMEs actually said that in the first meeting. Been true to it. Fine. And SMEs, feel free to. I think I might be frozen.
Sarah, you're breaking.
I froze there for a second. My apologies. I think I'm back.
Okay.
Yeah.
You
Vermont,
froze up.
yeah. Vermont is being Vermonty today. This is the yeah, rural internet access is
I understand perfectly.
yeah. Next slide. I don't think we missed too much here because I remember, I can tell when it froze. And so this is the English language proficiency concepts to align with the reading and writing elements, and they all hail from the National Latino and Asian American Study. Next slide. And then we are resting on the brilliance of the I Speak primary language assessment methodology because it is so accessible and inclusive. We do recognize that there's gaps in some of the languages represented, especially in, so we're still willing to add any I Speak instrument that fills a gap, because often for the different indigenous languages, they're not in the federal instruments, but they're in state level sets. We saw that in Arizona, and an Arizona set that Gerardo helped us find. But I just want to note that this is the I Speak instruments are hyperlinked to the master, as we mentioned before, because many of the statements are images and therefore can't be transferred to the master list. I do recognize that the fact that they're images makes it really difficult to read as an alt reader. So I was thinking about bringing this to our SME meeting tomorrow. How complicated it is if your primary language assessment can't be read by an alt reader because it's an image. But next slide. Okay, I think that's it with the assessment instruments, right? Next slide. You can see one slide back. I just want to note that, my apologies. So this is the, on the left side, in our query for ensuring representation of American Indigenous languages, this is what Gerardo found for Apache, Hopi, Navajo, Pima, Yaqui, and Yavapai, right? So we don't have, I'm looking for the American Indigenous languages that are not based in Arizona or northern New Mexico, and we are just continuing to be on the hunt for those. But just note that we are really trying to lean into representative languages, and you can see Central America represented in the middle slide. Next slide. Anything? Okay, we're doing good. Okay. Now leaning into programs and professions, and you're going to see these on the master, definitions to come. There's references linked, right? Because I really want to make sure that everyone knows that if it made it onto this slide, it means it has a reference and a solid definitions coming. Next slide. So generally, and it can be hard to orient, we have this all social determinants of health intervention value set, because the core roles and professions and programs across all of the social risk domains are very common, right? So referring to community health worker, peer support, social work, care and case managers, community action agencies, those advocacy orgs, right? They're never not going to be helpful. So those are all, of course, dumped, right? Because it's just never not a good thing. Next slide. But in our normal way, we are pulling forward concepts from other domains. And so we first actually identified language access as a domain of reference in our work with health literacy. So we pull forward all of the interpretation and translation concepts from health literacy that we work to develop there. There's more to come here. But for right now, these are the core, and they already have all the syntax, education about, provision of, referral to, assessment of, right? So the ways that we build syntax and gravity, these are pulled forward from our health literacy work. And just noting that this is how it was actually Gerardo on that call 2 years ago, I think, Gerardo, that led us here. Just took a little bit of time. We got here. All right. And so these again are going to be on the master on Tuesday. Next slide. I think that's it. And so just noting our work as to facilitate the subject matter experts is going to try to wrap around preferred language, like how we would state that. Because one of the things that we're thinking about is like what's helpful to have in a record and a problem list, right? What do I like intervene on, right? And so we're going to be talking through tomorrow about the other concepts in language access and language barriers, and if they do need to be represented as a problem statement or a social risk, or if it's just a statement of fact, and might require a different, flow than our normal screen, diagnose, goal, intervention. But more to come on that. We're now going to shift. Any questions on language access? We're going to shift into incarceration status. It's kind of, I think we're, it's at that point where it's like this concept is starting to settle, and there's starting to be a little structure, which is nice. Okay, incarceration status. And again, I just want to note, many of our brilliant subject matter experts are on the call today. We are having really, really intense and lovely conversations on how to do this right, and really grateful for the guidance of our subject matter experts across both of these domains. I mean, like equity is like a concept we think of 24/7 when it comes to these concepts. It's always, of course, part of our work at Gravity, but these two domains have us really leaning in deeply to it at this time. Okay, incarceration status, next slide. Super grateful for these amazing subject matter experts. We have friends across DOJ and the VA health system. We introduced last time our brilliant new subject matter expert, Kwesi. We have clinicians who are involved in the direct care of formerly incarcerated individuals. And so we really have this dream team, and incredibly grateful for all of them. And I just want to note, it was Milan and Radha in the beginning, at the ARM meeting, who helped spawn this a long, long time ago, coming up to me after an Academy Health presentation. Next slide. All right. So just restating the obvious. And again, I don't know if Milan is on. Oh, she is. I don't want to put you on the spot, but I do want to note that we are in this balance here with this domain, really trying to lean into telling critical stories, but not trying to do it in a way that exacerbates harm. And especially always because of the weaponization of incarceration, thinking through lenses of equity and historical structural racism and discrimination. So it just has us in this very, thoughtful place. And luckily our subject matter experts are brilliant in guiding us through this work. I am daily humbled to work with them. So just noting that we really are leaning into the benefit and risk concept with these. And again, really critically, always thinking about the structural forces of the weaponization of incarceration and structural racism as we do all of this work. Any other SMEs want to comment on that balance and how we're thinking through it, or have I done an okay job? I'm assuming quiet means that I'm doing an okay job. You all are so brilliant. Just pipe in at any time, because all I'm trying to do is represent your expertise. Next slide. So I just want to note, you're going to actually see this theme come back. As I mentioned with language, although it's outside of the scope of gravity to lean in to developing training modules, we are a data standards initiative. We are really trying to call out how critical things like staff training are when we are gathering sensitive data, and really trying to ensure that we are naming ways to be accountable to any finding in our work. So just noting that, again, this is kind of building off of what we said in the previous slide, is we want to develop terminology that supports identification of the trauma, mental behavioral health concerns, and social risks that are associated with incarceration. And we're decentering the incarceration itself in our terminology as we go forward. But we also just really trying to ensure that we understand, what the intent is. And I'm going to name this, and I say it later. We were on the cusp of possibly not having any instrument to screen for incarceration per se. There's a conversation happening in the SME, between the SMEs, about whether that's appropriate, even if it's time boxed, right? So I just want to note that if we coalesce on the on the fact that screening for incarceration history itself is just not the intent, and that screening for needs associated with incarceration is the intent, you might not see the instrument that we see later on the slides on the master, right? I'm just giving the SME's perfect, authorization to come to consensus over the course of the next couple days. And so if they settle on that, they won't be there. Next slide. And if any questions, feel free. I'm just, trying to get through. I'm just speaking to what the SMEs have said, but if anyone has any further thoughts, let me know. So these are the concepts we're coming up with insofar as naming concerns and naming elements. Next slide. So we have our primary concepts are incarceration subtypes and community supervision concepts, and missing in there really is these concepts of reentry statuses. If we remember, one of the opportunities and the use cases for why this is important are waivers that are trying to bridge the historical healthcare access gap, right, and address the known intense risk of social determinants of health for formerly incarcerated individuals, right? And we are leaning into possibly terminology to support that use case. The critical need for assessment after release from incarceration. That window, it's like a different kind of transitions of care, like not from the hospital, but from incarcerated settings. And then we also are leaning into, we had thought we did different types of risk assessment and secondary concepts of loved one incarcerated. I want to note that because all of the loved one incarcerated concepts that we have are issuing right now from elements of the ACEs instruments, this might be appropriate because we haven't delved into it too much to be addressed in the next cycle, because it's the CDC Kaiser Permanente risk assessment and the California ACEs instrument. Those are areas that we're pulling that family member incarcerated from, but more to come on that. Like, we are accountable to it, just trying to figure out where it fits. Next slide. All right, so we have currently incarcerated concepts, and these are fairly straightforward. One of the things that our SMEs are universal on is the need to differentiate, if possible, where a person is incarcerated, whether it be in jail, prison, or juvenile detention, because the risks that they come out with are significantly different depending on the location. And we're working on concepts of whether we can create concepts that talk about that window that's critical for reentry waivers, and really for community reentry in general, about the discharge planning element. We are not leaning into that at this time. So Jonathan, we can talk more. I'll bring that back again from a we haven't, I can have my SMEs let me speak to that, but we haven't leaned into that concept. It was actually, there were some significant concerns regarding the possible bias of that statement. Christy?
There's my mute button. Hey, yeah,
Hi.
hi. Yeah, this is great and a great summary. Thank you so much. I wanted to mention that in one of the things that we've been thinking about with the data standards working group that we're doing with public health, and in the housing tool to discern status with regard to McKinney-Vento, but also looking into residence and congregate facilities and including correctional facilities. We have been thinking about because we do, have a we could obviously get responses with regard to a correctional facility that someone is currently residing in. So we'd want to reflect that in terms of their current, housing status, if they're currently housed in a congregate facility that is a correctional facility. We've been thinking through kind of just looking at where these two things kind of intersect. We've been looking through kind of what is the desired kind of level of disaggregation, and we've kind of gotten jail, prison, detention, and I, kind of something that I'd be curious to hear the SME's opinion on, whether in this fora or afterwards, would be one of the things that we've been talking about is if we should be sure to distinguish between a federal and state prison, and then also for detention, juvenile detention centers versus other forms of detention, such as in like an ICE detention facility or other types of detention. So would love to hear any thoughts on that, or have follow-up conversations. I just was something that was brought to mind by this slide. Thanks.
Chrissy, I think that we can lean into, if we go into the next slide, I think it might help. You're right on the money there.
I set you up, Cecilia.
I know you did. Right. I'm
Okay.
going to lean into the last thing first. We've had a lot of, well, not a lot, we've had a couple really lovely conversations in this meeting regarding the intersection of the experts in immigrant health and the experts in incarceration, and how to represent, sorry, this domain makes me so, may make me so emotional. But how to represent those who are in, detention because of their migrant status, and and how, like, whether that's more of a risk than a benefit. Luckily, we have the SMEs on hand to kind of work through that. Julio, I don't want to put you on the spot. We were talking about we were passionately discussing this. I think it was our second meeting. We do have a planned huddle. And again, like later in October, trying to merge both of our SMEs groups to discuss just that, right? A little deep dive, sharing information across our incarceration SMEs and our immigrant CDC immigrant health SMEs on just that topic. So that's the answer to the detention center element. And then we did talk briefly about other types of detention and haven't leaned into that yet. What you're seeing here is what we solidified. There's a few other things in the sandbox. Regarding Jonathan's house arrest concept, you'll see that we rolled that up into a general community supervision concept. I think, I'm trying to remember, friends, because of the bias of stating things like that. Like, what does a person need to know, right? We definitely did not put forward things like electronic monitoring of specific subtypes. Rada, I see you're coming off. Do you want to lean into that?
Yeah, can I just make it, and Milan and Quessy, please check me on this if it's not an appropriate blanket statement, but our big thing was the focus needs to be on how it affects people's health and their healthcare. And so that's what we really honed in on. And just to go back to what Christy was saying, that sounds like it probably needs to be in a different conversation, which I'm sure that quite a few of us would be happy to have in a different space.
Yeah, I think Christy was mentioning that well, because we're definitely, the use case for today is definitely the healthcare use case posted. Yes, 100%. So happy to circle back around. Does that sound good?
And I would agree with Rada's statement.
Yeah, no, absolutely. And yeah, I don't want to derail the conversation here at all. I will say that our work in public health is expected to then connect with a proposal for a data standard that would apply to health IT and USCDI, because so much of public health data, even now, but even more so in the future, will be coming through healthcare channels. But yeah, I would be really happy to. I really want to, to benefit from the expertise of this group, but happy to do that in follow-up conversation. Over.
Fantastic. Okay. All right, moving on. What I wanted to mention was in the currently incarcerated concepts, we did not lean into the different statuses of federal versus state locations, but we have done this in the reentry concepts. If we go into the next slide, the focus on the reentry concepts is really, and Rado, you just said this very carefully, right? Like really trying to make sure we're representing concepts that tell critical stories for people that can be told from healthcare settings to aid the person, right? So this is the, the uniqueness of where we are. So we have two different SME groups, and we're gonna try to work to like synthesize them, but there are these time periods that matter from an acuity perspective and from a phases of transition into community perspective. There's really three, and we keep on kind of going back and forth regarding which building the terms that matter. And I just want to note, like everything in italics but not bold is something that we're not going to be supporting, right? I just put it there because it's like a placeholder. It's the parent concept, because we're very, very intent to try to work with SNOMED to ensure that our concepts are time boxed, right? Like this is something that's been very, very clear from our subject matter experts. Like we really want to make sure that we're not creating concepts that can linger in a record and be used and impart bias to the person. Like this is, again, I set us up, we were talking about data principle number 6, but this is where we are. And so there's one of our SMEs is, we have these 3 different concepts. We'll settle on them eventually. And then our job is to work with SNOMED-CT to ensure the ethics that is driving these statements is kept as we try to go forward. And there's more to come on that. Anything, SMEs, that you want to lean into here? No, this is all you. Thanks, Quincy. Great. All right. Next slide. Okay. And then I think I'm correct, right? So we initially kind of parsed out all the different subtypes of community supervision, including things like house arrest and electronic monitoring. And there were really strong feelings that that level of detail was not required, right? So we have Jonathan, I'm trying to circle back to the concept that you stated, right? So these community status concepts are being represented as this. It's like, how much information do you need? This level's probably enough. More is not necessary, right? And in this instance, you can see the parent concept we're aiming for a submission for that, because this is an instance where the provider might not know, right? Whether they're in a treatment court or a problem-solving court, right? There are definitions incoming on these. And so there is really luckily we have so many clinical friends in our subject matter expert group. We are rich with people who are actually leaning into the care of like individuals. So this is an instance where we likely are going to be leaning into both the higher level concept and the lower subtypes when able.
Sarah, can I ask a quick question?
Yeah.
And forgive me, I might not be thinking about it in the right way that it's being defined right now. So one of the things that comes up is like because like kind of like structured racism that's baked into like a lot of things like criminogenic scores and different things, but also gets at like, do you have a relative or a direct relative who's also been incarcerated or different things? Anyway, the whole targeted justice impacted communities, are we getting at any data elements that get at like communities that have been historically and currently targeted and like in any kind of way? Are we trying to, is that part of when you say community status concepts? Is that part of that same bucket, or is this a different bucket concept altogether? Do you know what I'm saying?
I do know what you're saying. I'm going to look to our brilliant SMEs to answer that one. That's definitely not me. Like, I don't know. I don't think we have yet.
Like even I think
Word
in,
community,
oh, go ahead, sorry.
yeah, the word community here is referring to specifically community supervision rather than a
I see.
community that is impacted by incarceration.
Okay, perfect. Thank you.
Thanks, Keith. I didn't understand the question. I thought Alina was asking something else. But Alina,
Are we going to be defining those kinds of things in part of this?
that's what I understood. The latter part is something, I mean, I don't know. I don't think that's been in scope to date. I think we really are trying to tell person level stories right now. But I know that's a good question.
Because I will say, like, our use case, like in California, right? We've got like funds that come from like marijuana taxes, and they're trying to be like community reinvestment. And so, like, a lot of grants come out and like, how do we prioritize communities that are historically targeted, essentially from like a justice impact lens, and the data elements, because they don't really exist, it makes for its own trickiness. Anyway, so okay, cool, thank you.
Can I just say, like, I think we all know or should know that Black and brown folks across the United States are clearly and significantly negatively affected by mass incarceration. And so yeah, I mean, like, I guess I struggle with knowing like what level of data needs to be collected by that, like when it is obvious. Sorry.
Yeah, it's like a water is wet kind of data set.
I hear you.
Maybe, excuse me, Lena, maybe another way to conceptualize getting the data to help yourself might be appreciating that those who are experiencing social justice, there's other ways that data is collected about their experience that may not be from this data set specifically. And in that way, the movement may not be about what I'm identifying you as in the present moment versus what your experience has been. And then how does the resources that are available to you uplift that space?
That that was kind of what my question was. I'm just a bad typist, so I wanted to make sure that I got it out quickly, right? So my question was really more like when you think about being under house arrest as a form of incarceration, like do you capture that under incarceration status or do you capture that under housing insecurity? That was more of my question.
And I would appreciate maybe a way to answer that question is under community supervision, just the umbrella of under subsumes that you're under something that you may not want to be a part of, and you're placed into that. So community supervision or house arrest or any term that we might identify to a human being that's experiencing something also creates the intentional bias around how that person is in that situation, period. So what we're trying to do is not necessarily dive that way initially. And I appreciate the idea that we need to capture. Sometimes when we try to capture, we get so granular that we miss the intent.
That's right. That's right. That's exactly
right. We're trying to be sensitive to the idea that words can take on so much different ways of meaning. And the provider has a limited amount of time to assess the information, and how they communicate that information must be bidirectional. So the person they're talking to also has to have a vernacular that makes some sense to what you're asking the question for. So if the bias is even in the vernacular, in the way that we ask or receive the question, I may not answer the question to you, Jonathan, that might make sense to help me because I receive it a way that's too granular or too fine.
That's right. That's right. That's right. That's right. Thank you for clarifying my question. I appreciate that.
Julio, we see you. And Christy, I think your hand's still up, but I think you asked your question. Julio?
Sure. I just wanted to underscore what was just stated in terms of the granularity. For example, when we've attempted to address issues of incarceration in the context of HIV diagnosis and prevention and treatment services, we as a governmental agency were unable to engage in it directly through incarceration, but we were through housing, right? And through our housing partners. So I don't know if we will have the capacity or the bandwidth to figure out out the wording to account for how healthcare and allied health services are put into funding practice. But I want to, you know, underscore how sensitive that might be, because some of the built-in constraints that agencies have, particularly around the issue of incarceration, among other issues. Over.
Thank you, Julio. Nicole asked a good question here. Like, given people's desire to do right, have any of you ever published or do have access to like a best practices in language regarding this domain? Is there such a thing? We talk about it in our work, but does it exist in the community?
Go ahead,
Go ahead,
Kwasi.
Malone. No, go ahead, Malone. I back you.
I was just gonna say, I'm not familiar with a best practice guide, so if you know of one, Kwasi, but I was going to say to Kwasi and Radha, perhaps this might be something we want to think about with like ACCJH putting something together and forward. But there are definite I'd say there's consensus about really emphasizing person-centered language, not defining people by the spaces that they've been confined to. And so like reentry is an acceptable term, you know, an individual or person who's experiencing reentry, someone or a person who's experienced incarceration or has been formerly incarcerated, but we definitely don't support you know, calling people ex-offenders or inmates or felons or any such labels. And additionally, there's also, you know, criminal legal system versus criminal justice system. The field is really moving towards defining it as the criminal legal system because it doesn't deliver justice to everyone, and on the whole, in many ways, doesn't. But I don't know if others know of a document. Oh, perfect. I see Radha put something. I'll let Kwasi also speak.
There are some SAMHSA has a bunch of language and papers around reentry language because it's specific to substance use. It's from a trauma-informed lens that it's asking not just the provider or clinician or administrative team to think through what the language we use. It's also the body language. It's also the position of the room. It's also where you put the chair. For those of you on the call that are physicians, you're often trained that, you know, when you walk in, your back is to the door. Well, for a person who has lived experience, your back to the door means I can't get out. So all of a sudden we're already in a binary just by that. So I'm not going to hear you because I'm thinking, how do I get out of here? So I think that we could expand this conversation in another space. And I think it would also be useful, Sarah, in the spaces that you're sitting in, that we think through how do we inform with basic concept paper. And then as far as ACCJH, I think it's something that we can expand even farther out, because each person on this call, I would believe, has to develop their own rhythm around how they would use trauma-informed language for any population that we're talking about. It's just that we subsume the incarcerated space to be so sensitive versus being proactive to say that this is still a human being. And you would think about this human being in the same way that you would if it was a person who has, let's say, a traumatic brain injury that you can't see the effect of. You would still be thoughtful in the way that you talk to that person or hear that person. So I would ask everybody to begin to appreciate that the status of somebody who is incarcerated does not subsume them to have some kind of language, and not coming from Star Trek. You know, like the person isn't getting beamed down. And if you would be informed when you're talking to someone else with an experience, you would be informed talking to this population. And I recognize there's nuance. And I want to uplift that, and happy to help us think that through. There's a bunch of stuff that I have on my own. I call them snippets that I use that I can share out with everybody. But I would also offer, we can have an and statement that you have gifts and talents. Apply them to the same way that you would be thoughtful and intentional with anybody else. More than likely, your intent will land.
Thank you. And I just want to say, like, this is part of what we are talking about. I hear you, Kwesi, and I think we, to whatever degree we can attest to the sensitivity to which we are trying to do this work and the reasons why we made the decisions we made. So not just the concepts we're submitting, but like the ethics we tried to follow and why, right? And that artifact can be part of the final work. So not just the SNOMED submission, but, you know, the why it's this, right? And like some kind of thing, and again, not as sophisticated as what's to come, but happy to support in all of you as subject matter experts in that statement, and then that statement being made in consensus and supported by consensus in this space.
I would be especially interested in hearing more of those snippets. I think the example that you gave of the clinician-patient interaction and how lived experiences impact that is really valuable as we try to articulate use cases for these questions. So, like, we're not trying to define vocabulary in abstract. We're trying to make it easier for people to have positive outcomes. And so if we articulate those use cases as, I am a discharge planner, I'm a clinician or a case manager working with a patient who has both pregnancy and incarceration as things that I need to work with. What is the right vocabulary to make sure I'm able to connect this person with the right resources? How do I find those resources? And how do I understand and record the details that are relevant to making sure this person gets the best outcome?
Thank you, Keith.
Okay, I mean, Sarah, so when I was on the Infineon call, and I know there's some things became more salient to me, right? It was about, and I'm paraphrasing, getting the terminology for people to be able to take it out and use it in real world use case scenarios, and then informing us on how to improve upon that, right? And so when we talk about like not boiling the ocean being too granular, it's being able to speak in broad enough generalizations that we can actually get the information out there, but then actually capture how it's being used in real world scenarios, and then refine it, but then also giving them transparency on how those terminologies and those use cases were developed. Does that make sense?
It makes sense. Yeah, and I think sorry.
To both points, Keith, to your point, Jonathan, some part of this is, let me be clear about this. How a person or a treatment team or a system takes information and practices that within that system and coaches their clinicians, their system up as to how to be thoughtful in language is also a part of the hope.
Mhm.
Oftentimes, at some point in time, to your point, Keith, to your point, Jonathan, we have to have spaces in which people take it upon themselves to huddle around, how am I communicating? What am I using to communicate that language? What is the way that my best practice can come through?
That's right.
It can't be on the document itself. There is work that individuals and groups and teams can do, and we can participate in lifting that up and creating a culture that people can take that moment to say, wait a minute, to Keith's point, what's going on here, and how do I make sure that I'm documenting something that can affect a healthy outcome to the best of my ability for this human being or for their progeny or whomever. That is real. And there has to also be a system that provides Keith the space to do that. If the system doesn't provide that space, I don't care what we write, what we do, he's still in the fray. So I just want to honor the joyful discomfort of what we're doing right now. Like in this moment, I think that's cool. And I want to lift up the fact that, like, yo, we got to wrap some hands around Keith and John and be like, yo, we got to give people some love so that they can do what they got to do and give them a little bit more time than just the billable 15, 16 minutes that they got to handle with people. That's also a real.
No, that's right. That's exactly right. That's right. Well said. Thank you, Sarah. I'm sorry I got us derailed. I apologize. I have a tendency to do that. That's part of what I bring to the process. So thank you for being patient.
Thank you all. Any other thoughts on so I hear the documenting the use case, and I hear like I mean, the great thing is we have all these, we are in a use case. We have a why. That's what's brought us here, right? So putting that, clearly explicating that and the ethics and principles that guided us to our ensuing findings, I think is a good thing to do. And I'm happy to lean into that. Okay, so I think, I think then the next slide, I'm trying to keep us. There's some updates here. So really, again, keep thinking about the work you were speaking to trying to do with people. And this is a blank right now because it's a to be determined, but this is one of those instances where we may come to consensus by the end before we post the master. So this might not be a blank by the time you see the master on Tuesday. So what you see us trying to do here is decenter the incarceration element and center the person in their story and the needs they have, right? We know in our kickoff slide, we talked about how histories of incarceration affect employment and housing and food security. And we know how it affects healthcare access and social connection and family connection. Right, so we have been reflecting, and we did this last week on Friday, on how to tell that story in a way that allows the person's need and their person's story to be the focus, right? Not the incarceration element to be the focus. And we've done this before, like when things are when like transportation insecurity affects food security, we've told this story before, right? Or when when we clearly have evidence that one need intersects with another, we've told this. And Kwesi, you were so eloquent. You were eloquent just now, but also on Friday, and like holding up the idea that legal involvement, because we were using the word legal histories or legal involvement for a bit, and then Kwesi really elegantly spoke to the fact that legal involvement is not always negative, right? That we can have positive experiences and positive legal histories. And so that would be confounding a bit to center only the negative nature of that involvement, right? And not to say it's fine. So this is where we are. And so right now it's a blank on the master. But one of the things that that I reflected on, and I've talked through with a couple of the SMEs, I'm just going to talk a little bit about the concept of legal needs over the next slides. This isn't consensus yet. The SMEs have not all reflected on this, but this is something we're going to be discussing over the next couple of days. Of maybe this is a path forward, because there's a lot of literature from the medical legal partnership world regarding legal needs and social needs and healthcare outcomes. Like legal need being my story as a person. It doesn't matter whether I have a civil history. It doesn't matter whether it's a criminal history. It doesn't matter whether I'm the victim. It doesn't matter whether I, whatever. Doesn't matter. I have a legal need, right? So we're gonna go, okay. Okay, and we're going to the next slide now. So that's what they're at the master. And so what you're gonna see over the next slide is some of the works of the National Center for Medical Legal Partnership. I want to just call out our dear friend Samantha Morton, who's not here right now, but was one of our great MLP SMEs for many of our domains. And I just wanted to call to light some of the, because what we need to do is find a concept. We also need to defend it and have a reference and all of those things, right? So one of the things I just want to call to light, not saying that it's the answer, but I just want to elevate the fact that there is this concept called health harming legal needs or legal needs in the MLP world. And if you look at the iHelp instrument that they have, which is that call out here, and we should be dropping it into the chat, you can see that how legal services can help. It doesn't matter whether it's civil or criminal, how you can help. You just need help, right? If you need help advocating because you're getting denied a job because your history of incarceration, we've got you. If you need help, getting like help signing a lease because you are an IPV survivor and you don't have credit on your own because your former partner destroyed your credit, they've got you, right? So there's these stories about how legal services can be helpers, right? And it really made me think, and Kwesi, I elevated this in the email, it made me think of that story you were telling and how this is, number one, maybe a pathway that can be protective, because this does not mean the person did anything. It just means the person needs help, period, right? And those are the stories we're trying to tell. So there's a lot of literature. Again, more to come on this, but I couldn't, when I was reflecting on this really powerful conversation we had on Friday, I just remembered all of this lit out there, right? Because it's just, you know, and it could be referenceable for us in our work. And then another thing that I found comforting, if we go to the next slide, is that the last link and the next slide is very clear on some of the accountability measures that we always talk about, right? The MLP, Medical Legal Partnership Performance Measure Set, measures whether your healthcare staff have been trained. They measure where you're getting screened for the legal needs. They measure whether they're being addressed. They measure if they got a referral to legal aid. They measure all of these things, right? So by design, again, because they're, you know, true justice, not questionable justice focused, some of the accountability methods we know are important are already in there, which is nice. So all of those materials should be available in the chat. And if we could just go back now a couple slides to those concepts. So here, right? So what we have to do is figure out what word goes on that blank, right? And maybe legal needs is an option, and we'll talk more about that as we go forward. But we did not want to center the incarceration status alone, because that is not the point at this point. The point is that the person needs help, right? We did not, we were careful to note that just putting in legal history or legal involvement was problematic, because legal history and legal involvement is not always a negative thing, right? And then, so we are exploring ways to go forward. And then maybe legal needs is a way to do that. I think, and there's also, you know, I just want to note, because our SMEs are SMEs, when you look at the areas they told us to address, it directly aligns with MLP. So if we go to the next slide, you can see, again, back to the iHelp instrument on the next slide, you can see, here, hold on one. You can see income, housing, education, legal status, personal, family, and stability, right? So those concepts that we were already trying to tell. Oh, great. Okay. Yeah. And this is one of those bombs that I threw into an email, because you know, just because I only have one job, and that's to try to facilitate all of your brilliance. Right. And so you all had such, and I just want to note, like you really hit, it was such a powerful statement what you said on Friday. So I just tried to figure out how to do that. Hold it up, and there's some literature that we found. So we'll see if it fills in the blank or not, but regardless, it's lovely lit. And more to come on that. We'll talk about it over the course of our next meetings. Next slide. Okay, we're almost there. Okay, next slide. We're just going to talk about some programs now. So we're moving beyond, again, the concepts of the instruments. Again, everything you see on the next slide, it might not be here on Tuesday, because we don't know if we feel, there's not consensus among the SMEs about whether or not they feel comfortable for screening for incarceration only. I mean, like, it's still here because it was elevated early. It's just something we have to sort through. So I just want to note that this is one of those things we're going to be leaning into over the course of the next few days. Like, do we feel comfortable having a screening for incarceration approach as a standard? Or do we want to decenter that and not? Right, that's more to come on that. Next slide. I'm going to go into some programs and professions before we go. I'm just trying to get through so that you're not surprised by things you see on the master. Next slide. There's nothing else besides the incarceration status update. So again, all those critical community connectors are here: community health workers, social workers, care and case managers, etc. Again, all of those critical legal professions and helpers, MLPs, attorneys, non-attorney legal advocates, and legal aid, those are all in there. Next slide. But we're also really leaning into the core professions and programs specific to this domain. Again, purple also came up in the program work and related to the CDC housing work. So this is why it's here. But these are all programs and people or professions that we've identified as being important. And so you will see them on the master, and there's references to support them or SMEs have given us over time. Community-based reentry programs, forensic peer support, which is a specific type of peer support. We talked about peer support and mental behavioral health peer support, and you know, SAMHSA related peer support in the past, and this is specifically leaning in to the domain of reference here. Parenting from prison programs. Even if we did the VA programs, we somehow did not have this one. So I think, right, so this is pulling forward from our veteran status work and augmenting that, and then the housing concept. Next slide. And I always just try to, I don't know if Smeeze, if you saw this slide, I try to tell hopeful stories, right? Because if you don't know how this happens in practice, if it all seems very abstract and opaque to you, it doesn't have to, because like 4 blocks from my house is the amazing Burlington Community Justice Center, which is the raddest place. It's so great, right? And it is the center for the community-based reentry program funds from my town. It does community-based, non-clinical, non-DOJ related reentry care management and advocacy with people and neighbors. It does circles of support and accountability to support people reentering. It does restorative justice programs, pretrial support, diversion, all of these things just for the really wonderful people, right? And it's just like a real life example of how this gets operationalized in community in like community accountable ways, like neighbors supporting neighbors. It's a wonderful, like open door place where anyone can walk in and get help, right? And it's a place I refer to on the regular. I'm like, oh, you don't know about, let me tell you about this place, right? And it has never been anything but lovely. And there was one program I realized we didn't call out yet, the circles of support and accountability. Like that's a really great thing to refer to. So I threw that in the sandbox, and the SMEs will talk about that tomorrow. But I just, for those of us who are far from the like direct helping of all of this, I want you to know that this work happens even in like Burlington, Vermont, with like 35,000 people. We have a really rad community justice center, which is like the place I send people who need advocacy. Like you want someone to fight for you, they will. Go there. It's good. And we just, all of the programs they talk about are available. So if any of you want to explore, I thought I'd put the chat in there. Again, I just don't want this to seem abstract or unattainable, because even in tiny New England towns, this work is happening. Next slide. I think we're there. Oh no, one more. Okay, sorry. So this is these are domains and programs that are new, but not just related to this domain of reference. And so they're new plus, right? So these are programs that were identified by our SMEs as being important, but they're not just limited to this domain. They're applicable across many domains, right? Recovery, housing, family reunification services, the Strengthening Families program. So you'll see ACF all over this because it's about families. You know, just identifying that these are services that we that refer to and that exist to support people, right? That were identified as being important because our SMEs care about helping people, and they're not just limited to this domain. All right, next slide. I think we're almost there. I think this is it. Oh, mentoring programs live here. That's a good question, Melina. We have the forensic peer support program. I don't know if that's that. I'll take that to the SME sandbox SME for the SME meeting tomorrow. But that's a good question, Elena. I think about mentoring happens in many of those programs that we mentioned. I don't know. We only have like a few minutes. I don't know if SMEs want to say anything more, but that is all of the love it. Okay, wonderful. Okay. Great. Okay, I'm just going to try to capture that. Oh, wonderful. Okay, just watching this be smart. All right, I think we're close to time. Next slide. We're just going to go to the homework. There's no updates in the cross-domain terms. Very, very grateful. So these are just, there's nothing new here. So I'm going to skip to the homework if we can. We have had a really lovely conversation. I'm so grateful for our SMEs across our 2 domains. Really, there's just so many critical ethics that are interwoven into our work, and you all exemplify that, and we are grateful for you. For those of you who want to do the homework, if you have any thoughts on missing concepts, send them along. gravityproject@hl7.org if you want to review the master. No, the master is not going to be up on Friday. It'll be up on Tuesday. And just thank you all for coming to this space. Thank you for our SMEs for being such guiding lights. And we will see you for this meeting on this topic in 2 weeks. But if you want to come to program classification and coding for food next week, come join us. Thank you. You all are lovely.
Thank you.